All right, awesome. So before I kick it over to our speakers today, I just wanted to cover housekeeping items. So if you have any questions, feel free to use the Q&A feature to ask any questions you have. Hopefully, we'll have some time at the end to address those. We are recording this session and we will publish both the recording and share the slide decks with everyone by email and publish them to our website and YouTube channel. Our speakers for today's sensitive data session are Nicole Sweeney, who's the General Counsel and Chief Privacy Officer at CRISP, and Megan Redding Tercio, who's an assistant professor at the Columbia University School of Nursing. With that, I will turn it over to Nicole to start us off.
Thanks so much, Kevin. And it's so, excuse me, it's so good to virtually see so many of you today. My name is Nicole Sweeney. As Kevin said, I am the General Counsel and Chief Privacy Officer here at CRISP. It is a very fun role to have. And one of the things that I like the most about this role is trying to figure out how we take consent laws and ideas about patient consent and marry them to technology solutions, and then also feed that back to patients and our clinicians to make sure that they understand how these laws and technology solutions impact their day-to-day work and how they potentially interact with patients. That's my favorite thing to do, and I get to talk about it today, so I am thrilled. So I'll be spending probably the least part of this session giving a pretty short overview of some of the laws that may impact the data that our users see, that you all see every day, so that you know, hey, if I'm looking at this patient's chart, what could potentially be missing because there's information that is super protected legally. I'm going to try not to bore anyone with legal stuff. Usually the only folks that like talking about laws in depth are other lawyers. So I'm going to try to make this as entertaining as possible. And then we'll turn it over to Megan to talk about the really cool stuff, in my opinion, which is, how do you take this information and these legal constructs and have a conversation with patients about their data. So with that, can you move me on to the first slide? So I thought, what would folks like more right after lunch than a pop quiz? So a quick pop quiz. And I'm going to do a overview of this rather than give a pop quiz because that seems really mean. But I'm always curious what folks think about what the federal law, specifically HIPAA, allows. And so my husband told me that this is actually not a fun thing to do at parties, so I stopped doing it. But I had a lot of fun when I would occasionally talk to folks and say, hey, what do you think happens when you go into a clinician's office? Because I'll tell you, as a patient, right, and we're all patients, when I go into a clinician's office, they typically hand me a stack of papers at intake, or now more likely a tablet, and say, hey, here's some stuff. Can you update medications that you're on? Make sure your insurance is the right insurance. And oh, by the way, there's a consent form in there to make sure that you're consenting for us to share your information in various ways. And so before I became a health attorney, I thought that's what I was doing. I thought that I was, I didn't read every word. I thought I was consenting to my information being shared. What's really going on in most clinicians' office, and this is the pop quiz, is what you're getting as a patient is what's called a notice of privacy practices. It's not a consent. You do sign it, but what you sign is an acknowledgement. What patients are signing, right, is an acknowledgement that they saw this notice of privacy practice. I've seen notices of privacy practices where patients will write an X through the whole thing or write no or say refuse to sign, that doesn't mean that their data can't be shared. In fact, as long as they continue to seek treatment under HIPAA, their data can be shared for treatment payment and operations with other entities, with other providers and payers, and with their business associates, the folks that they have contractual relationships with to hold that data. So my experience has been that most patients think that their data they have to consent to their data being shared, but that's not the case in most situations. And there are an asterisk on that, like self-pay and a couple of other things. But your data is, as a patient, most of your data is going to be shared unless it requires what we call here at CRISP affirmative consent. So, well, you can score yourself on that part of the pop quiz. And then the next slide, I'm merciless. I have one more pop quiz. And this is a true or false. So you got a 50% chance of being right. A clinician, true or false, a clinician gets to decide when and how they send data. I was kind of mean on this one. This is like it depends, which is a lawyer's favorite answer to every question. In most cases, it's considered information blocking if you are excuse me, if you are what's called an actor. Most providers are actors. There are exceptions to that, including state law privacy exceptions. There are also exceptions around policies and procedures, so you should absolutely talk to your attorney. But I know a lot of the time, both as users and as patients, sort of have this idea that, like, oh, if something seems really sensitive to a patient, I can just decide not to send it. And that's usually not true. Again, this is like a very, it depends, but it's usually not true uh, unless there are certain exceptions that apply, including state laws. So, for the most part, as a clinician, if your assumption is that data is being shared about your patients all the time, and when you pull up your screen and when you pull up CRISP, you're going to see all the data available there. That assumption is correct most of the time, or at least as much data as CRISP has on that patient. But there are some exceptions that we wanted to talk about. So I wanted to first, again, just sort of set the stage by making sure that like everybody's on the same page about how data is shared, and that data is shared everywhere all the time. And that's pretty much what's going on, but there are a couple of exceptions. So next slide, Kevin. So just to really bring this home, I created a little bit of a visual. I'm definitely a visual learner. So this would be in most situations, if you're a HIPAA covered provider or facility, which almost all of our users are, or at least all of our participants are HIPAA covered providers or HIPAA covered payers, your data can go, a patient's data by visiting a HIPAA covered provider can go to payers, other doctors, other facilities without the patient's consent, as long as they're other HIPAA covered providers or business associates of other HIPAA covered providers. So again, just setting the stage that most of the data is allowed legally, and under information blocking has to go unless there's an exception to various places. So now I want to switch gears a little bit and talk about some of those exceptions and what you might not see in a record, but might still be true about a patient. So next slide, Kevin. So the first area where we think of a lot, the federal law, and many of you have probably heard of what's called Part 2. Part 2 refers to this section of the regulations, and it's in 42 CFR Part 2. And again, this takes us from just going back to what we talked about a second ago. Normally data, right, can flow without patient consent. As long as it's in the HIPAA covered entity realm, it can flow without patient consent. So now what we're talking about is data that requires a patient to sign a form, right? You actually have to sit down. It's not that notice of privacy practices anymore. This is a specific form where I say, I'm Nicole Sweeney. I want the data to go here, and it's only going to go there if I sign on this dotted line and I am informed appropriately about my consent. So the big federal law that requires what we at CRISP call affirmative consent, that's how we distinguish from the implied consent that we just talked about, where you just show up at a clinician's office and you're consenting by implication that your data can be shared under HIPAA. So affirmative consent is that actual sign on the dotted line. And 42 CFR Part 2 is the federal law that folks typically think of, myself included, when we think of laws that require affirmative consent. So to be covered by 42 CFR Part 2, this would have to be information that's at an entity, which is usually pretty easy, that it's holding itself out as providing substance use disorder treatment services and receives federal funding. The federal funding could be Medicare or Medicaid. So this applies to almost everyone. So most people are providing information. Most people are an entity. Most people are receiving funding of some sort. So this really hinges a lot of the time on whether something is 42 CFR Part 2, on whether a facility is, quote, holding itself out as providing substance use disorder treatment services. The way I think of this as an attorney, or the way I try to explain this, is if you could sort of look at a facility, look at the name of this facility, or go to its website and see that it's providing substance use disorder treatment, then it's probably a 42 CFR Part 2 facility. To kind of explain this with something that's not a 42 CFR Part 2 facility, an emergency room might provide substance use disorder treatment, but it's not holding up a shingle. It's not saying, hey, come to us if you need substance use disorder treatment. It's just sort of ancillary to showing up in an emergency room. So an emergency room wouldn't most of the time be covered by 42 CFR Part 2, but a facility that is putting itself out there, that is advertising its services, that is saying, like, come to us, or this is something we provide, would be covered by 42 CFR Part 2. So this is one of those circumstances where if you have a patient that is receiving care at a 42 CFR Part 2 facility and they have not signed an affirmative consent, they have not signed on the dotted line that they want the information to be shared with their treating providers, this might be missing from your record. So we wanted to highlight this as one of those federal laws that require affirmative consent. And then the next slide. And since this is CRISP is intended for the state of Maryland, I wanted to focus primarily on Maryland laws. So the other area, and this has only been rolled out, and it might not have been rolled out to all of the providers in our audience, all of the users in our audience, but a recent law that requires affirmative consent for certain reproductive codes related to abortion, and probably soon gender affirming care. So that's not yet, but I'm going to put a little asterisk on that. So this is, unlike 42 CFR Part 2, this doesn't regulate the providers. It regulates EHRs and HIEs. So at CRISP, if we see these codes in a record, we either take them out of the record before sending out a record that's put together of a bunch of different codes, or we'll block that record entirely if it's only one record. I'm going to say that again just to make it a little simpler. So if a record is coming from a provider that are specific codes, and we have links to these codes that we can provide on our website. They're also available in the Maryland Register. If it's one record with these codes, then we're going to block the whole record, because you could figure out by the fact that some information is missing that I received abortion services. But a lot of the time what we do at CRISP is we're actually taking 10 records about Nicole Sweeney and we're putting them together, and then we're showing that to you in one record. That's what we call a federated document. If we're doing that, if we're taking data from lots of different places and putting it together in one record, you would see everything else that happened at that service where I received that abortion care, except for the specific codes that are redacted. Likewise, if you're in our portal, you'll see everything else that happened at that facility or at that encounter, except for those abortion codes. But again, if the patient hasn't consented, if the patient hasn't said, yes, people can see this data, you won't see it at all. That's only if the patient consents to that data. So this is another area where you might be missing data if your patient hasn't consented. So just another area in Maryland that we want to highlight for you. Next slide. Even though this is Maryland specific, I did want to point out a couple of other common laws or common areas of sensitivity that might be in state laws. I know Megan's going to talk about this a little bit too. So, HIV testing and HIV status is often something in some states, including Massachusetts, that might not be available unless the patient's consented. So that's something to think about. If you know you have a patient from Massachusetts, even if you don't, it might be a good thing to kind of keep in your back of your mind that this might be missing from the record. California also, it's similar to Maryland. It's not quite the same, but they also might have missing reproductive data, including data about abortion encounters. Many states have very specific statutes around behavioral health. So that's another area where you might not be seeing that data. You're also almost always going to be missing psychotherapy notes because those require affirmative consent too from a federal perspective. And then there are other restrictions that you might not see for various reasons. Data surrounding adolescents, especially in Maryland, adolescents from 11 to 18 you might be missing parts of their data for various reasons. So that's something else to keep in mind too. Next slide. So I've been talking about this throughout, but I really wanted to bring this home. So if you're looking at a patient's record, for the most part, and Chris, you can assume that any data that's been given to us, you're going to have availability to, right? Because we talked about that at the beginning. A patient doesn't have to consent to their non-affirmative consent data, which is a funny way to say that, being shared. But you might be missing things if a patient hasn't consented to specific data. So some things to keep in mind, again, are substance use disorder treatment information. One of the things that's really impactful here is medication-assisted treatment. Medications related to medication-assisted treatment, so buprenorphine, which is a word I can never quite pronounce, and naloxone. So that might be something that you would be missing from the record that would really impact patient care and potentially what prescriptions that you have if it's coming from a 42 CFR Part 2 covered facility. Codes related to abortion in Maryland. Probably one of the most important things to think there is mifepristone data. So that would be a medication that would likely be missing from the record without affirmative patient consent. And then behavioral health diagnosis and psychotherapy notes in general, no matter where you are and where your data is coming from in the country, that is often an area where things are missing. So just keeping that in mind when you're treating patients, that you might be looking at a document or looking in our portal and thinking, this is the full patient record. And it is, except, or as much as we have, except these cases where there are intended gaps in the law to super protect these data without affirmative consent. I think that's the end, but I can never remember exactly where I end on things. Yes. All right. Well, I hope this was helpful from a legal perspective. I'm now very excited to turn it over to Megan, who's going to talk more from a clinician's perspective. Thanks, everybody.
Fantastic. Well, thank you so much. And I'm going to share my slides as well and just get them pulled up. Just want to affirm that everybody can see these okay and that you're looking at the slides and not the presenter view.
Yes.
Okay, fantastic. Thank you, Kevin. So thank you so much for the invitation to come join you all today. It's really, truly a pleasure. My name's Megan Tercio. I'm an assistant professor at Columbia School of Nursing. So I have a background as a bedside nurse. I worked for many years as a cardiac nurse before doing a PhD, and now I do informatics research. And so a lot of what I do is really focused on the patient perspective, on patient engagement and empowerment through data. And so we've done a lot of research, myself and my colleagues, on how patients feel about data sharing in the context of increased data sharing for both clinical care purposes and research. And so I'm excited to share a little bit more about that with you today. I'm going to give a bit of the background and context on patient concerns and why we looked at this, and then show you a little bit about what we found in terms of general public perspectives on increased data sharing, talk a little bit about research specifically. And even though I know that typically health information exchanges are primarily for the purposes of clinical care, There are cases where the information can end up being used for secondary purposes in research. So it's sort of a relevant aspect of this. And then thinking a little bit about special cases where there can be proxies accessing charts and what data sharing may mean in the context of proxies accessing it. And by proxies, I mean things like parents of a pediatric patient or a caregiver or child of an older adult patient, things like this. And then we'll have some take-home points. So just to start out with a little bit of background and context. So anytime a patient sort of comes to us to seek care, they start generating all of these little electronic pieces of data or breadcrumbs. So let's take, for example, Bob, who comes into the emergency room with crushing chest pain, and it turns out he's having an acute MI. So Bob ends up being hospitalized, and this begins his entire medical record of care, right? He's approached by a researcher who wants to enroll him in a clinical trial to test out a novel drug, where he completes more data for that clinical trial, like patient-reported outcome surveys. And then maybe Bob decides that he wants to sort of take a more active role in changing his lifestyle. So he gets a wearable and starts counting his steps and walking more every day to sort of improve his overall cardiac health. So you can sort of see how through the course of this, there's all this data that's being generated. And of course, like number one, we want to use this to improve patient care. So there's been a lot of work looking at interoperability of wearable devices into electronic health records and what are the ways that we can standardize wearables data coming from a number of different manufacturers and products into the EHR. We've looked at how can we integrate research data better with electronic health records. How can, of course, electronic health records talk to each other better? So that's what our health information exchanges help us so much with. But I just show you this long list just to explain that there are also many, many purposes to using and aggregating this data beyond clinical care. And researchers are really interested in a lot of these other use cases, things like phenotyping, studying behavior change, doing population health research, developing AI algorithms, developing clinical decision support, and so on. So there's really tremendous value in these breadcrumbs. And just to go a little bit deeper into the electronic health record piece of it for a moment. So this is, as you all, I'm sure, are very aware, all that goes into a patient chart. There's a lot even just within that one little piece of it, from standard data, sort of structured, I should say, data like medications and vitals, to imaging data, to free text clinical notes. We can also see some wearables data showing up in there depending on the types of APIs that are set up, some genomics or omics data, social determinants of health. So there's so much that can be packed into this chart, and some of this may be considered sensitive health data. So just to give another definition of sensitive health data, this is data that, if disclosed, could potentially cause harm or distress to an individual, such as stigma, discrimination, or expose them to legal risk. And this may include sexual and reproductive health information, mental health, diagnosis and treatment, genetic and biometric data, substance use and addiction history, and in some cases, even health apps and wearables, particularly because more and more things like sexual and reproductive health or mental health are being tracked or documented in some way through our apps. And then you can think about how health apps and wearables can aggregate that data with things like your geographic location, and things can just get extremely personal really quickly. So there's a lot of reason why patients are concerned about this. Prior research shows us that participants are worried that the data is going to be misused in some way, that their data will be re-identified and associated with them. So even though in many cases for either research purposes or for clinical care, we may in some cases have anonymized data sets, there's a lot of research to show it's really not that hard to actually re-identify data that has been de-identified. And then people are also very aware that the data could end up in the hands of a company who could potentially exploit it for commercial gain. Certain sensitive data, like reproductive and mental health data, can evoke additional concerns, particularly as we're seeing different changes to reproductive rights across different states. And then, of course, underrepresented groups that have been historically marginalized or mistreated in the context of research and medical care can be wary about data sharing because they have had this history of injustice. So, what are some general public perspectives on data sharing? So, just to kind of give you a high level, we've done a number of studies with participants who we've recruited through national surveys. So, these are national panels of 500 to 600 participants, just trying to understand a little bit about how people are feeling about all of this. And one of the things I like to start out with is showing you this graph where we show you the level of trust that this panel of this, in this case, it was 500 US adults have in different groups of people in their life. And what you can see is that the dark blue here is that these are people that the participant deems strongly trustworthy, and the green is trustworthy. So family and friends really make the top of the list here. Most people think their family and friends are either trustworthy or strongly trustworthy. And then doctors and nurses are one rung below that, and actually local businesses are below that. And then at the bottom, you see things like the internet and large corporations. But what's interesting about this is that when you actually, this is kind of like their baseline trust in these groups. But then when you ask them, well, who do you want to share your data with? Who do you feel comfortable with receiving your data? The trust really kind of flips. And what you actually see is that groups like friends and family are actually the group that people want to share their data with the least. So in this survey, 23% of people said it would decrease their trust if the data were shared with friends and family members, even though they were the group that on the previous slide people trusted the most. People are willing to share with like researchers and want the data back themselves more. So I share this to say there's a lot of nuance with when it comes to how people think about where they want their data to end up. And I think there's also even more nuance when you think about the fact that participants recognize that there are differences in the types of data that can be shared. And people, without even realizing that there are such things as sensitive data or not sensitive data, and may not know the definitions of those things, actually inherently sort of self-identify the sensitive data and have differences in how they want to share those data. So just to give you one example, in a separate survey with 600 US adults, we asked people about data sharing preferences with all these different groups by specific data types. And in this one example, you can see that sexual health and fertility data are on the left. So this would be an example of more sensitive data. And then imaging data, which in many contexts is less sensitive, considered less sensitive data, is on the right. And so what you can see is that whereas 88% of people were willing to share imaging data with doctors and nurses, only 75% were willing to share their sexual health and fertility data with doctors and nurses taking care of them. And when you kind of go down the list here, you can see a pattern where there's generally higher percentages that were willing to share the imaging data with different groups compared to when you go over here to the sexual health and fertility data. There's generally less willingness to share sexual health and fertility data, kind of regardless of this recipient. And then same thing when you give the example of mental health data, which again is a bit more sensitive compared to other general sort of clinical symptoms that someone may be having. You see that 90% would share clinical symptom data across doctors and nurses taking care of them, but 77% would be willing to share mental health data. And again, the percentages on the left here are much smaller than the percentages on the right. So a lot of reticence with data sharing when it comes to these sensitive data elements in the public. And then also just want to point out that we do see some differences when we look at participants' racial and ethnic group. So in these bar charts, white is the participants who identify as white are the red bar. Participants who identify as Black are the orange bar, Asian is the green bar, and another race is the blue bar. And you can see that there are some big differences between the groups when it comes to sharing sexual health and fertility data with different recipients here. And same thing with genetic data. There's big variability. In fact, I think in all 4 of the panels that we show here, there's quite a lot of variability. So again, the point here is just to drive home that there's an incredible amount of nuance that's kind of layered into this that has to do with kind of this multifaceted matrix of who's the recipient, what type of data is it, and what is my kind of personal background, and what am I bringing to the question of data sharing. So we see this really bear out when we look at qualitative responses that people give us as well. So participants really support limited access to data for a lot of these sensitive elements. This person said, while I agree that it can help make positive changes, I would 100% want to know which outside companies they're talking about sharing this with before I'm willing to share it. It does decrease my willingness. People advocate for greater autonomy. So this person said, though I completely understand the positives of what making information public would bring, people still deserve the right to choose to have the type of data private. People really prioritize remaining anonymous. So this person pointed out by combining information from multiple sources, it's possible to de-anonymize data. If you know my age, zip code, and income, you're a long way towards knowing who I am. And finally, people want transparency in understanding where their information's ending up. So this person said, I'd need to know exactly which public groups have access. Are we talking about neighbors? Are we talking about insurance companies? I'm just going to touch briefly on research data because, as I mentioned, primarily in the context of a health information exchange, we're really referring to data being shared for the purposes of clinical care. But it can be possible that researchers can use this data in certain contexts for population health studies, right? In that case, it gets a little bit tricky, right? If the person is funded by National Institutes of Health, because in 2023, NIH actually created a new policy saying that anyone who's funded by NIH needs to make the data that they collect as part of their research study publicly available so that other scientists can go in and verify the conclusions that they're drawing. It's basically supporting the idea of scientific reproducibility. And this is generally a good idea, right? But of course, there's so much nuance to this, particularly when you think about researchers who use electronic health records as part of their data set. So researchers can certainly carve out exemptions and say something like, this data that was shared, that we collected for this study is too sensitive, or we're legally bound to not share it. But that's not always the case. It's really quite nuanced. And so the challenge is that participants may not necessarily realize this because they're granting kind of broad consent, and there's language in the consent form that explains where their data is going to end up. But the question is whether participants are really grasping that, and whether they understand all of the potential future uses that could be happening with the data. So we asked people about this. We recruited 600 participants shortly after this new NIH policy was announced in 2023. And we asked them again about the types of data they were willing to share and different external groups. But most importantly, we asked them how this new policy would affect their attitudes towards participating in research. And interestingly, we found that most people actually agreed with the idea of this data sharing policy, but between 9 and 23% of participants strongly disagreed with this updated policy. And so this is a pretty sizable minority who strongly oppose this. And for many of them, it would actually change their willingness to participate in a research study. In fact, 28% of Black or African American respondents said it would strongly decrease or decrease their willingness to participate in research, which is notable because these are individuals who are already underrepresented in research. So this new policy could potentially be deterring them. So I think there's more work to be done in this case. And certainly I think we see a lot of the same themes coming up when we ask about attitudes towards data sharing in the context of research around anonymity, autonomy, and transparency. People say it's my information and I should be in charge of where it goes and who can access it. And some people are even quite skeptical about safeguards and say all the policies in the world are great, but there's no safe data. So people are really concerned. And I think just the main point here being that when research is involved, it can it can make the whole process of data sharing and the moral ambiguity around it much more ambiguous. And then finally, I want to spend a little bit of time talking through a lot of the nuance that comes with the pediatric perspective and relatedly sort of other proxies accessing medical records when they're taking care of a loved one. Let's say it's a parent or a family member or friend that you're taking care of, and you have access to their medical record, and sort of how we think about sensitive data in that context. So my colleague, Dr. Marianne Sharko, she's a pediatrician at Cornell, and she has led a lot of this research that I'm going to be presenting today. This is just one of the papers that she has published on this, really thinking about this in the context of pediatric portals. So in the adolescent population, of course, we all know there's a high risk for having sensitive health information. It's part of being an adolescent. So there can be concerns around behavioral health. There can be concerns around mental health. There can be concerns around sexual and reproductive health. And unfortunately, we're seeing that there's a rise in a lot of these concerning or risky behaviors in the population. So the CDC every year does the National Youth Risk Behavior Survey. And what we can see is that between 2011 and 2021, a lot of these behaviors that they're tracking have actually gone up. So, for example, this is showing persistent feelings of sadness and hopelessness, and particularly in adolescent females, there is a pretty significant rise over the 10 years that they were following this. Similarly, and this is really quite a stark increase, the proportion of adolescents who are considering attempting suicide has gone up. In fact, 30% of females endorsed this in 2021. And the proportion is even higher when we look at LGBTQ plus youth. And at the same time, the proportion of adolescents who are using safe sex practices, such as using a condom, are going down in both male and female adolescents. So what's important about this is that there are a lot of risky behaviors going on, and in many cases, it's pediatricians, family practices that can be the touch point for people to be disclosing this information and potentially be a resource to be educating on the importance of this, to be connecting to vital sources like resources like mental health services that are needed. And adolescents really need privacy to be intact before they're willing to share this sensitive health information. There have been tons and tons of studies that have confirmed that if adolescents don't feel that there's going to be privacy between them and the person taking care of them, then they're not as likely to disclose that information. It's tricky in the context, and I know Nicole touched on this earlier, of increased data sharing. So we have things like the 21st Century's Cure Act, which actually prohibits us from withholding certain information because it's considered information blocking. And so just to make this a bit more concrete, here's a really nice use case that kind of walks through what we're talking about. So let's take Maria. Maria is 17 years old. She lives with her mom and dad, she lives with her mom, but visits her dad in another state. In her home state, Maria can consent to confidential contraception, and so she's been prescribed oral contraceptives. But Maria goes to visit dad. Dad has a history of violence. Maria develops painful urination and forgets her oral contraceptives. So then she tells her father that she doesn't feel well, and he takes her to a clinic. Through an API, her PHI is shared with that clinic. Laws in this state allow the healthcare provider to disclose her oral contraceptives to her parents, but the pediatrician declines to share that information for her privacy and safety. So Maria goes on and privately discloses her symptoms. The pediatrician informs her that she can consent in this new state without her dad's permission to testing and treatment for an STI. And Maria consents, and the test comes back positive. However, through a proxy portal account that Maria's father has set up, he learns about her STI medication. He learns about her OCPs. Also, he can see information about the lab tests that were conducted in the after visit summary and in the billing explanation of benefits that comes from insurance. And Maria's father becomes angry, and now Maria is fearful for her safety. So this is just an example of how kind of there are multiple touch points of data being shared, and at any point it can kind of leak back to somebody who's considered a proxy for this person. This is a good time to pause and just point out that there are different terms that can be used in this space when you're talking about this. So there are some institutions have set up adolescent portal accounts and then parent and guardian proxy portal accounts. So this is a way of kind of differentiating the data access that different parents or guardians may need depending on what the type of data is. So sensitive data can be, in some cases, shielded from a parent or guardian. And this is something that's controversial. I'm not going to pretend that this is something that has sort of been widely accepted. I know that parents are concerned about this, and I'm a parent myself, and it's hard to imagine not having vital health information about your child. And so it's a tricky kind of situation that I think the landscape is really still evolving as we continue to have discussions like this around the different aspects of considerations and around the sensitive data for adolescents. A study that was done in JAMA a few years ago showed that even though a lot of health systems have kind of gone through the trouble of setting up different portal accounts for adolescents and for parents, a lot of parents are just simply logging into their adolescent's account and just kind of interacting that way with the health system. In fact, this study showed that more than half of adolescent accounts were probably actually accessed by guardians at least once, and they looked at 3 different health systems in this study. In a study that my colleague Dr. Sharko did, she asked adolescents, they were over 18, I think 18 to 25, if you thought that your parent would look at your portal and see all your health information, would that change how much sensitive information you share with your doctor or nurse? And more than half, so 55%, said yes. The reason I noted the age, so 18 to 25 or 26, is because those are the adolescents who may still be on their parents' insurance. And so there can still be complexity, even though they're legally an adult, around the fact that there's an insurance tie to that parent. There can be different portal policies at different health systems. States have enacted different laws and regulations around this. And then there's kind of entire facets of care. But it all kind of amounts to like a Swiss cheese approach where all of these different policies and regulations don't always align evenly. And so in some cases, you can have data kind of leaking through the system unintentionally. So for example, just looking at different facets of care, as a person kind of goes for care, the patient presents to an office, and then the PCP sort of collects a lot of data on them. The parent may see some of that data. The front desk staff may see some of that data. The EHR kind of houses a lot of sensitive data. Some of that gets filtered back to the portal, which then may go back to the parent or the patient through various portal mechanisms. And then, of course, there's also things like specialists who access that EHR. There's health information exchanges. There's payers and billing systems. So there's kind of all of this movement of data. And you can see how the orange, which is possibly sensitive data, and the red, which is definitely sensitive information, can end up in a whole lot of different places. Okay, so this was another study that Dr. Sharko led. This was published in 2022. This is a very busy table. So rather than focusing on the details, what I just want to point out here is that she did an analysis of each state's laws on the ability for a minor to consent to medical services. And the color is just representing the different nuance to that law. So you're meant to take away here that there's a lot of color on the screen. You can see that there's a lot of variability and a lot of differences depending on the specific states to things like the age in years to consent for medical services, immunizations, dental care, sexual assault evaluation, STI treatment, HIV treatment, contraceptives, prenatal testing, illegal substance use, mental health treatment. They also included Maryland in this paper if you're interested in having a look. However, I would caution you that this paper was published 3 years ago, so it's probably best to also just kind of look at the most recent laws as they're published on Maryland's governmental websites. But there's just a ton of variability in the laws and regulation by state. And then similarly, there's a ton of variability in the way that different health systems have enacted these policies within the context of the states that they're operating in. So this was another analysis she led where each of the rows here is a different medical center or hospital. And you can see again the amount of color here because there's different ages at which the IT system deems an adolescent to sort of be of age. So the youngest age is age 10, all the way up to age 14, at which these kind of adolescent portal protections start to go into place, or certain sensitive data may be blocked or withheld from certain parent or proxy accounts. Okay, and then lastly, I just want to touch on this idea of hidden proxies. I've kind of already alluded to this, but just to give it a name. So health systems can set up for portal accounts formal proxies. So maybe you've done this. I know I've done this for my kids. You've gone in and actually kind of set up a proxy account. So the system knows that you are not that patient, but that you are a person who needs access to their medical record. And you have, for example, my kids are age 4 and 1, so I have access to pretty much all their information, because they're not at that adolescent sort of sensitive age. But the reason why formal proxy accounts exist is because in certain cases, and we just went through a lot of examples of why this is important for adolescents, but also want to point out that this can be the case for older adults as well, where their children or others that are taking care of them have access to all of their medical records. And that may be something that that patient is deeply uncomfortable with, depending on what's in the medical record. Maybe it's something from their distant past that they have not disclosed to their family member. Maybe they actually are disclosing situations related to elder abuse. For all of these reasons, this can be complicated, not just for children and their parents, but for a lot of proxy situations. But what we see is that there's a lot of studies to show, and this is a study that my colleague, Dr. Benda, Natalie Benda at Columbia did, to look at hidden proxies. And we can kind of find evidence that there are people who are logging in to the patient's account directly and acting as a proxy, but really they're just going right into the patient's record. And the patient's usually saying, here's my name and password, and just go right into my account. So my colleague did this in the case of an oncology hospital in New York. And she was really looking to actually use natural language processing to find sort of hints that in the portal messages that the patient was sending to their oncology care team, could they find evidence that there was actually a hidden proxy that was sending those messages rather than the patient themselves? So they looked at this NLP algorithm to classify those hidden proxy messages, and then they looked at whether there were any differences by patient characteristics. And what they found, they looked at over 12,000 patient portal accounts, and of those, 10% had unregistered or hidden proxies. And they found a lot of differences based on the patient's sex. So this was more common with males, more common with participants who were classified in the EHR as being of Asian race or another race, participants who English was not their primary language, older adults, and participants who were on public insurance. So really, I think just trying to raise awareness that this situation of unregistered or hidden proxies is not all that uncommon, and that can further complicate conversations about how we're sharing data, because even though we can try to put safeguards in place to protect sensitive data from the kind of formal proxy accounts, people may just be going right into that person's account and seeing everything that's in that chart. Okay, so finally, just the last few minutes here, just want to kind of touch on some take-home points. So I think it's safe to say we know now that we will never have all of the information. Sensitive health data is blocked for a number of reasons, and patients have a lot of concerns about that data sharing. And so this is kind of leading to uneven filtering of information between health systems. So just as you would always verify some critical elements about a patient before you start to take care of them, and I think allergies is the perfect example, you should always kind of verify certain sensitive health data that is very important to taking care of that patient. So, for example, if a person came in and either their allergies were not on file or it said no known allergies, pretty much always you would still ask them to confirm that they don't have allergies before you go ahead and prescribe something or administer a medication. When we think about digital data sharing and digital tools, the ethics of data ownership, consent, transparency, and trust are sort of central to this conversation. And I think we saw how uh, transparency and trust are really kind of the interconnected pieces of this. And so as we think about future work, particularly those of you who are really interested in this, ways of sort of like increasing trust and facilitating transparency, I think are going to be really important talking points, discussion points for us. Data sharing is actually something that people really care about. That was something that was surprising to us when we first started this work. We thought that people may not have all that strong of opinions about this, but they have really strong and really nuanced feelings about what data goes where and who's accessing it and what they're doing with that data. So I think in order to kind of further this conversation, we probably need to be having a lot of different stakeholders and viewpoints as part of it in order to kind of think about how we do this in an ethical way and sort of mitigate this risk of distrust. And finally, just this lack of clarity on the uses of data can really erode trust, especially among communities that are already hesitant to participate in research, communities that are already reticent to share their data with different health systems and maybe sort of underrepresented in these conversations. So with that, I would just like to end and just really thank all of my colleagues, including those that are shown on the slide here, Dr. Marian Sharko, Stephanie Nino de Rivera, who is going to be a medical student starting in the fall and has led a lot of this truly phenomenal work. Ruth Masterson-Krieber, who is a professor at Columbia Nursing, as well as Dr. Nat Benda, my colleague at Columbia Nursing. I think we can stop sharing and possibly open it up for questions if that sounds good.
Thanks so much, Megan. And thank you, Nicole. Super informative session. Nicole, I saw you were answering some questions in the chat as Megan was talking. Is there any that you want to highlight or anything you want to say further on those?
Yeah, excuse me. I probably should have said this at the beginning. This is usually the thing I say at the first sentence, but apologize to folks that I am an attorney. I am not your attorney. So folks that asked me for legal advice, I had to say, like, please ask your attorney. And I'm sorry, I wish I could be more helpful than that. And then there's also a question about, like, what if I don't want this data to be shared with CRISP? So CRISP is, what if I don't want CRISP to share this data? And I wanted to point this one out a little bit more. So if you have data that you don't want CRISP to share, you should not send it to us. Because unless we're prohibited by law, we have to do our own sort of information blocking, and that's a different conversation for another time, analysis, but to make sure that we're complying with law, unless there's a law that says don't share this data, right? So we're not going to share it willy-nilly and, with secondary researchers and various things like that, unless it complies with our policies and procedures. But if we can share it, if we can share it with another clinician, then we will. So if you are worried about a type of data that you're sharing with us, we always tell folks, don't send it to us, because we're going to share it unless there is a law or a policy or procedure or something like that that's going to prohibit us. But I also really encourage you to talk to your attorneys, because there might be reasons that you need to share that data, or different pros and cons of not sharing that data. I do want to also just pull out a thread that Megan was talking about as well, and this person asking the question was asking about. So we don't have a way in CRISP, at least right now, for patients to access their own data, which also means that parents can't access the data. They might be able to access your data through another EHR, for example. Like if you are on the Epic network, they'd be able to access it through the Care Everywhere app. So that's something to think about as you're doing these analyses and thinking about data sharing. But CRISP does not have a patient-facing application directly, which in some cases is can be difficult for patients. I can talk about that at length. We'd like to get there in the future, but it's very expensive to do identity verification. So now we rely on the national networks for that, which is a different conversation for a different time. I've probably said too much, but let me stop there.
Well, that was great. Thanks, Nicole. Um, I just saw you typed out a lot of responses, so I wanted to make sure you could clarify or abstract to the larger audience. Um, Megan, is there a way that folks can find some of the studies that you showed on the slides? I think you had some links there, but is there any website that you would point them to?
Absolutely. So I would say that probably the easiest way is to look at the slides. And what I can also do, Kevin, is send you an added slide that just has a final list of the studies because they're kind of currently sprinkled throughout the presentation. So it'll be a little tricky for people to kind of track them down. So I'm happy to share a list of several of the studies that I have really highlighted if people are interested in reading more.
Someone asked if you were affiliated with CRISP, and to be clear, we invited Megan because we know she's a great speaker and she has a lot of great insight, and her team did a lot of research. So we just wanted to share that with you guys.
Thank you.